I'm Dr. Corey Cutler. I'm the director of the stem cell transplant program at the Dana-Farber Cancer Institute in Boston, Massachusetts. And today we'll discuss challenges in the treatment of steroid-refractory chronic graft-versus-host disease. Despite improvements in chronic GvHD prevention, transplant patients still do suffer from chronic graft-versus-host disease, and steroid refractoriness is really an important consideration for our patients and their long-term health. Now, we do have 4 FDA-approved agents for the management of steroid-refractory chronic GvHD, all of which are approved either in the second line or the third line. But understanding how to properly sequence these agents continues to be a real challenge for us clinicians. It's great to see that now we no longer have to wait 3 to 6 months after starting a second or third line agent to determine if the patient is going to actually respond, because we have now subsequent agents that we can offer our patients. We used to wait this long because we didn't have active agents, but with the newer drugs on hand and knowing that most responses to these newer agents will begin to be evident by 8 weeks or so, it allows us to move our patients onto next line and potentially more effective therapy when they are not experiencing a good response to the drug that they're currently on. Now, one problem that we still have is that we don't quite understand how to correctly select the right agent initially for the patient who is sitting in front of us. What that would take would be expanded access to biomarkers or other biologic information that can accurately predict response of a given patient to a given drug. And we certainly do have some markers that can predict response once the patient has started taking therapy, such as a rise in regulatory T cells in the case of drugs like interleukin-2 or belumosudil. We don't yet have a marker that will predict before the patient starts taking therapy which drug will work best in this patient. So most of us continue to use clinical features. It's important, along with the clinical features, that we choose a drug that's going to have an acceptable side effect profile. And of course, every drug has a unique side effect profile, certainly which limits its use in some patients and not others. And oftentimes, it is the side effect profile that guides our decision-making the most. So we have to make sure that when we're considering the balance of potential efficacy and safety, we consider the patient, their quality of life, which is, of course, paramount to our selection. At the end of the day, everything we're doing is really to try to make our patients' lives better.